Good morning, everyone. Today I'm going to present a seminar on disorders of consciousness. My moderator is Dr. Sanjeevani ma'am. Um, First of all, we'll start with alertness. Alertness is basic arousal process in which the awake patient can respond to any stimuli appearing in the environment. Alert but inattentive patients will be attracted to any novel sound, movement, or event occurring in the vicinity, while an attentive patient can screen out the irrelevant stimuli. Attention, if a patient is attentive, that means he is alert. But an alert patient does not necessarily means attentive. Then attention. Attention is ability to attend to a specific stimulus without being distracted by extraneous internal or environmental stimuli. Attention can be active attention or passive attention. In active attention, when the subject focuses attention on some internal or external environment. So when this type of attention is disturbed, there is distractibility. Distractibility is disturbance of active attention. Passive attention is when the same event attracts subject's attention without any conscious effort on their part. There are 5 aspects of attention. There is selective attention, that is concentration, attention capacity, sustained attention, divided attention, and alternating attention. Selective focus attention, also known as concentration. It is the capacity to highlight the one or two important stimuli while suppressing awareness of the competing distractions. Attention capacity refers to the fact that only limited amount of cognitive processing activity can be carried out at one point of time. Sustained attention or vigilance refers to the ability to maintain attention activity over a period of time. Then there is divided attention, that is able to respond to more than one task at a time. And alternating attention is the ability which allows to shift in focus of attention and task. Then what is awareness? Awareness is attention plus working memory or explicit memory. That is to be able to selectively attend to a number of stimuli and a short-term memory stored into which these items can be loaded, held simultaneously and combined. Then is orientation. Orientation is one's awareness to time, place, and person. When consciousness is disturbed, it affects these 3 aspects in the same order. When the customary events which mark the passage of time are missing, it is very easy to become more or less disoriented in time. Then orientation to place is retained more easily because the surrounding provides some clues. And orientation to person is lost with the greatest difficulty because the person themselves provide information which identifies them. If the patient is disoriented for time and place, it means it is customary to say that he is confused. Disorders of consciousness are associated with disorders of perception, attention, attitude, thinking, registration, and orientation. Now in brain, we have reticular formation. Reticular formation are a group of specialized reticular neurons in the perimedian portion of midbrain and upper pons. So from reticular formation arises reticular activating system. These are a complex of polysynaptic pathways arising from reticular formation and hypothalamus with projections into intralaminar and reticular nuclei of thalamus. These nuclei from this intranuclear and reticular nuclei of thalamus further project diffusely and non-specifically to wide regions of cortex like frontal, parietal, temporal, and occipital cortex. So reticular system maintains a constant fluctuating stimulation of the higher centers. Without a steady input from the reticular system, the cortex cannot function efficiently, patient cannot think clearly, learn effectively, and relate meaningfully. Any damage to this system may make the patient difficult to arouse. So this reticular activating system is responsible for arousal, attention, sleep, and awareness. Limbic system input add emotional importance to the object of attention. Hippocampus consolidates information into memory and accesses stores of memory in neocortex. Amygdala gives sensory information a experiential or affective tone and expression of emotion through its connection with hypothalamus. Example, a student who is studying for a test is aided in the need to concentrate by a fear of failure or a drive to succeed. Now, what is consciousness? Consciousness is awareness to the external environment. It is awareness to the internal sensation, your awareness of yourself as a unique being having experiences, and your awareness of thoughts about these experiences. The critical element of consciousness is awareness. Now, Fish defined consciousness as a state of awareness of self and to the environment. The dimensions of consciousness are vigilance, lucidity, and consciousness of self. What is vigilance? Vigilance is basically alertness. The factors inside individual that promote vigilance is an interest, anxiety, and extreme fear or enjoyment. What is lucidity? It is clarity of thoughts. And the third aspect is consciousness to self. It is the ability to experience self and awareness of self that is both immediate and complex. Then is unconsciousness. According to Jasper, unconsciousness is not an inner existence, does not occur as an experience, or not thought as an object, or has gone unregarded, something that has not reached any knowledge to self. Now, dimensions of unconsciousness are deep sleep, coma, and unawareness. So consciousness is a continuum. It ranges in a normal person, it ranges from normal consciousness to reduce wakefulness to stages of sleep to deep sleep. In a patient with organic brain disease, it can range from normal consciousness to clouding of consciousness, drowsiness, and classification of disorders of consciousness. Disorders of consciousness can be classified into two: quantitative changes in the consciousness and qualitative changes in the consciousness. In quantitative changes, it ranges from normal consciousness, that is alert, vigilant, and lucid, to clouding of consciousness, drowsiness, torpor, coma, and death. And also there is heightened consciousness. And in qualitative changes, there is delirium, fluctuations of consciousness, and confusion. Clouding of consciousness. It denotes a lesser stage of impairment of consciousness on a continuum from full alertness to coma. So there is impairment of consciousness, there is slight drowsiness with or without agitation, and there is difficulty with attention and concentration. However, alertness remains normal. It is seen in drug and alcohol intoxication, head injury, and meningeal irritation. Then there is drowsiness. Drowsiness is next in level to clouding of consciousness. In this, there is diminished alertness. The patient is awake but may drift into sleep in absence of any sensory stimulation. The patient will be slow in activities, have slurred speech, sluggish in attention, and sleepy on subjective description. Will attempt to avoid painful stimuli, and reflexes will be present but reduced with diminished muscle. Next is torpor, that is general loading of consciousness without any hallucination, delusions, and illusions. These patients are apathetic, show no spontaneity when talked to. Their attention is hard to arise, cannot be sustained. They cannot concentrate and may perceive it. This type of consciousness is a result of severe infections such as typhoid or typhus. Then is coma. The patient here is unconscious. It neither respond to external stimulation nor to internal stimulations. The coma is divided into light coma and deep coma. In light coma, the patient may demonstrate some reflexes like decorticate or decerebrate. There can be movements, but no meaningful or purposeful movements. May momentarily arousable with strong stimuli. No verbal responses or response to painful stimulus. The rightening reflex for posture is lost. Muscle tone greatly reduced. Breathing is slow, deep, and rhythmic with flushing of face and skin. However, in deep coma, no motor response is seen. The patient is no longer arousable and deeply unconscious. Then there is heightened lucidity. This is exactly opposite of clouding of consciousness. It is state of wakefulness. The person experiences an intense alertness, prolonged concentrating ability, and hyperesthesias. That is, colors may appear brighter, sounds may appear sharper, and touch is more intense than usual. This is normal in healthy and adolescent at the time of emotional and religious crisis, and it can also occur in psychotic diseases like in mania. Then qualitative changes in consciousness. First is delirium. The cardinal feature of delirium is reduced alertness. If there is reduced alertness, then hence there will be reduced attention and concentration. The patient cannot ignore irrelevant stimuli and is easily distractible. Memory is impaired because of distractibility. He cannot register the information. Then also, there are perceptual disturbances, abnormal psychomotor activity, and sleep-wake cycle impairment. Disturbance in attention increases toward evening. That is, this is known as sundown. There may be autonomic nervous system overactivity in delirium, which distinguishes delirium from all other confusional states. Then fluctuations of consciousness. Fluctuation of consciousness occur in healthy people in sleep and in fatigue. Example, in epileptic patient, fluctuations can occur before, during, and after seizures. And also in delirious patient, there is diurnal variations in consciousness. Greatest lucidity is present in mid-morning, and the patient become more disoriented in evening. And confusion. It is loss of capacity for clear and coherent thought. It is simply a description of patient's self-experience or a doctor's observation. Now there are some other terms like dream-like changes in consciousness or aneroid state. In this, the patient is disoriented to time and place, but not to person. There will be visual hallucination, usually of small animals, that is Lilliputian hallucination, and associated with fear or even terror. And unable to distinguish between this mental image. The patient is unable to distinguish between his mental image and perceptions. So his mental images acquires the value of perception. Then there is twilight state. The term was introduced by Westphal. It is a well-defined interruption in continuity of consciousness. It is characterized by abrupt onset and end, variable duration from few hours to several weeks, and the occurrence of unexpected violent acts or emotional outburst during an otherwise normal quiet behavior. The commonest example of twilight state is seen in temporal lobe epilepsy. Now, Ganser's state is a sort of twilight state. Enoch and Rithuvan gave 4 main components of Ganser's syndrome. That there will be approximate answers, there will be clouding of consciousness, there will be somatic conversion of features, and pseudo hallucinations. Then mania apoto, pathological intoxication. It is a twilight state associated with alcoholism. According to Coyd, there are 4 characteristics of this condition. There is occurrence after consumption of variable quantities of alcohol, followed by a senseless violent behavior, followed by prolonged sleep, and partial and total amnesia for this violent behavior. Next is automatism. It simply means taking place in absence of any consciousness. It is an involuntary behavior over which the individual has no control. Behavior during automatism is purposeful and often appropriate. Afterward, the patient has no recollection of partial memory for his action. Example is epileptic automatism, most frequently occurring after discharge in the temporal lobe. It is characterized by a state of clouding of consciousness that occurred during or immediately after a seizure, and during which the individual retained control over posture and muscle tone and performed simple or complex movement and actions without being aware of what is happening. Then last is stupor. It does not lies in the continuum from wakefulness to coma. It is the inability to initiate speech or action, that is mutism and akinesia, in a patient who appears awake and alert. It usually occurs in some degree of clouding of consciousness, and the characteristic of lesion. It is a characteristic of lesions in the area of diencephalon and the upper stem, frontal lobe, and basal ganglia. And last is locked-in syndrome. It occurs due to injury in the motor pathway in ventral planes. In this also there is NR3 and quadriplegia, but in this the consciousness is preserved. Syndromes of akinesia and mutism in a conscious patient also occur in schizophrenia and affective psychosis and dissociative states. These are my references. Confused, there is reduced alertness.
Impairment of consciousness, clouding of consciousness,
So delirium is a qualitative change. So
consciousness तो ये है sort like quantitative change in consciousness. Come to delirium. Delirium is, you're saying it is awareness.
reduced alertness.
इसमें कहाँ पे आएगा?
So as per consciousness is the continuum. So it delirium does not lie in this
Completely conscious होगा patient.
Patient will not be conscious. There will be clouding of
There will be
consciousness.
some element of
Some
degree of impairment in, say, the consciousness. Okay. But as you said here, the hallmark is cardinal feature is
reduced alertness.
alertness. anytime when assessing the delirium patient, I tell you people, the residents also, when you say that the patient is disoriented and therefore you will delirium. Orientation is the hallmark of delirium. I think maybe somewhere around that. Last for orientation, if the patient is not oriented, use with that. If you study this, then you will know. Orientation is disoriented or delirium, it is not actually
Orientation we check to see consciousness.
right. So if it is not a hallmark that a patient is oriented or disoriented, it is not make specific and say impression that the patient is in delirium or not. If you see the usually we reduce if the patient is disoriented, then he will be having reduced alertness. That is a given. Okay, but anytime you see patients have fluctuating disease, and they may be that is not the hallmark. That is not what exactly you are looking for. Only orientation. You understand? The question is, delirium कहाँ पे आता है consciousness? So what you are saying is right. Actually, it is not. We will say the continuum of consciousness. There is a different differences syndrome, a different phenomenon. Where the hallmark is alertness. Okay. Diagnostic criteria also the focus on attention. What will you see for diagnosis? Because this is very critical course. To do patient and what will you see to say that he having concentration over attention. Strictly too much, he is not able to attend to new stimulus and he is not able to, as I said, ignore the distraction. Ignore the he is reacting. The stupor when the patient is not reacting at all. Delirium is moving around, is trying to think. So that thing is also even with the internal groups. Okay. That is it. Then you have perceptual like lots of other things. Okay. Let's say that if you go to the ICU, then there are most of patients who are coming out of consciousness or delirious state. Then you see patients who are sick. So they are aware, then they go into coma, the gasping. That is a different state. Okay. That you need to be able to differentiate. इसमें definition में describe किया है complex attention. होता है complex attention, one of the domains. Areas attention में क्या हुआ? तो 5 बताइए. State attention. Selected attention capacity, sustained attention, limits, divided attention, and alternative. Anything the clinical examination, how we can check this, these things, or motion capacity. How do you check this? It's that. It's that. Not more. It's that. Selective or focus attention. And sustained attention. Divided attention. Look at as it is. Alternating attention. Set shifting up. अगर आपका रिस्पॉन्स सही होगा तो सिलेक्टिव तो आपको सही करना उसमें पहले कलर से मैच करती है जैसे स्टार्ट so there set shifting that is also one of the features of right.
आपको कलर मैच करने शेप्स में फिर आपको शेप्स मैच करने कलर में लोग तो कंफ्यूज करते हैं ना उन्होंने सेम कलर दिया होगा लेकिन आपको सेम कलर मैच नहीं करना है आपको सेम शेप्स मैच करने हैं क्योंकि अलग अलग कलर ये आप छोटे बच्चों को देखिए आपने
Basically not related to psychiatry.
Everything relates.
Motor pathways in the ventral folds. So, because there will be patient will not be able to walk, so there will be quadriplegia and anatomy. But in this state, the consciousness will be present. While in stupor, the consciousness will not be present. There will be like clouding of consciousness.
Complete motor paralysis. Response. Hypothetically, that the foot respiratory muscle goes and the person not be able to survive. But if the voluntary muscles are only paralyzed, so in complete lockdown syndrome, the person is able to be aware, conscious. Like it can happen in anesthesia. Like if the patient is aware, but there is, you can say, still muscle paralysis. To intubate the patient. It can happen. Like the person is not able to react, but if you speak, motor part is affected, although the other conscious. It only people running because they see she's just lying there and conscious.
So patient anesthesia में है, but he has lost the motor sensation, but the pain sensation is there. So they are operating. इसको नाम याद है तो they are operating in the मतलब it really happens.
Anesthesia के तीन parts हैं. Consciousness, muscle paralysis, and analysis. All three have to be. So analysis will provide all these. Like if there is only impairment in consciousness, we move this steps. You can say that visualizing with the patient copy, so you require muscle paralysis, you require analgesia also. And sometimes happen that they check by pulse that is what they check. Because if the pain is there, then they will be tachycardia, BP will start shooting because of the autonomic. Can happen that there is like adequate analgesia. And if you've seen operations like the surgeon, certainly there is a movement of pregnancy. So, see.
So that is GX.
Final. So I think it's a good topic. Basically, because one of the main thing that we have to repeatedly do at times is differentiate a person who is having a normal behavior and at least you can say awareness, consciousness to differentiate it from anorganic. So, by the way of working with patients, you will know that the psychosis, even in the extreme form, there are if you go by the definition, then there is some aware of some element of you can say unconsciousness or unawareness of the patient towards his own stimulus is himself, what he is, that definition of like that awareness, not only about the surrounding, but awareness about himself. That may be lost in some part of psychosis. But you have to differentiate it from the other disorders, organic brain disorders. So that so we need to know this in detail. Okay. Stupor is difficult because it is like the patient is just unresponsive. So it can be dissociative also, it can be catatonia, it can be like the patient has encephalitis or let's say just comatose. So that you have to differentiate. So cross-sectional examination is not enough to diagnose somebody of delirium or so when you go to the ward, you also take a history how the patient has been reacting to when he's being injected, when his family members are there, is he talking to them, what is he saying, does he make sense? And you have to decipher the information about that event. Sometimes they are very emotional. You need some of the channel. So from the action, that usually when the nurse comes, but they will be taken care of. हमारे आने के बाद movement show करता है मैंने जो बोला पुलिस ने हाथ में तो सुन रहा है that you have to you see both the cases where a patient psychotic patient appears as a patient catatonia he will appear delirious patients or may appear specifically delirious they may appear psychotic. That is why you see we tend to think that the other branches they are not able to differentiate between delirium and say psychosis, but mostly they will see true that also, but they usually they see a decreased consciousness. In the sick patients who are stuporous, who are comatose, who are unconscious, not responding to pain in their Glasgow Coma scale, it will be very low, like not responding to external stimuli at all. Right? So they don't see patients who are actually responding with their falling consciousness. They are in the same hyper vision. So that for them, and we are not called for those patients. We also, when we go to ICU, so there is some selective bias in that. Many sick patients are there, but we are not always called for them because they are just lying there gasping many times for days, not responding at all. So for them, that is the you can say unconscious. You can say it is on the Glasgow almost feel this one. So the biggest patient that is like it. So world over it is like highest reference from psychiatrists for the other one. Yeah.
When they do AD analysis, it is also mostly okay. So that's why they say psychosis. But for accident it आ जाता है कि फिर भी उनका जो delirium है और alcohol withdrawal delirium they are vastly different pictures. Metabolically, इससे भी सारा confusion होता है कि ये psychosis है.
Also, they are saying a lot of patients like hyponatremia. They will be saying 10 patients. Not every patient goes into delirium, but every patient with that condition goes into delirium. There are some precipitating factors along with that. So that also like for them, like patient is lethargic. So that also very easy play on those. History में yes.
But I can नहीं मिला मेरे पास.
It is difficult. But usually you will see like we know the hypothesis is because of you say these like the brain neurons are hyperactive. So fascination, tremulousness, okay, agitation. This you usually see hypoactive delirium. You don't see. These are clues, but you can't completely say. These are clues. Like if somebody is hyperactive, you can say that, and there is a history of alcohol intake, like, for example, in the past, and 5 days we stop, and now it's not that people do. You should actively look for something else. That is clinical. Otherwise, you can't. Hyperactive delirium can be a number of things. So, you can't say that this alcohol withdrawal is again needed. You see a number of cases of withdrawal, you will develop a sense like you can say that feeling that this is alcohol withdrawal, this is wrong. But there is no concrete way of doing it. Clinically, you can say that hypoactive. You will see other, there are some other features, tremors are there, circulations, agitation is there. Okay. More in favor of. Plus the history. No history like this. Clues can be liver function test, DVT. These can be clues. But without a proper history, you can't do it.
And give prayer for you also. ऐसा कुछ show नहीं है लेकिन थोड़ा देख के idea आ जाता है कि क्या होता है.
ठीक है ना?
Thank you.